All right. So again, welcome to the Minnesota MAMES State Networking Session. We do have quite a few special guests on this call, and instead of introducing everybody, each individual, we're just going to have those folks introduce themselves. So we'll start out with our MAMES president, Al Newman. You want to introduce yourself for folks that I'm sure everybody knows who you are, but take that opportunity as one of our Minnesota board members for a long time and now as president.
Hi, Al Newman with Corner Home Medical. Glad to see everybody. I'm really, I don't know about you guys, but I've got that COVID blue kind of thing going on where it'd be really nice to see you guys in person, but at least it's nice to see all you guys participating. So welcome. Thank you.
Thanks, Al. And then we have our Minnesota State Chairperson, Minnesota Board Directors, been on the board for quite some time. And Jackie, want to introduce yourself?
Sure. I'm Jackie Semrad. I am Director of Compliance for Reliable Medical Supply and glad to be a part of MAMES. Not being a part of MAMES is a stupid thing to do if you want my opinion, because MAMES allows us to connect both on a business level and a legislative level, and it's, and thank you all for being here today.
Thank you, Jackie. And then our next MAMES Minnesota board member is Jack Beasley. Do you want to go ahead and introduce yourself, Jack?
Yeah, Jacques Beasley with Geritom Medical, Director of Purchasing and Procurement. MAMES has done a lot of great things, and I'm glad to see this networking event.
Awesome, thank you. And then we do have our MAMES Minnesota Legislative Chairperson, Tom Jamison.
Yeah, thanks, Rose, and thanks for hosting this. I think this is a great idea. I'm Todd Jamison. I'm with Lake Superior Medical Equipment in Duluth, and we are continuing to have to fight battles here in Minnesota with the Department of Human Services relating to Medicaid reimbursement or sometimes unreimbursement. Right now, we're fighting a clawback that they're trying to do. We can talk more about that later. I just really want to thank everyone for being part of MAMES and for all of you who are part of the legislative committee, the Minnesota Legislative Committee. We really appreciate all your efforts and attention and support of what we do. So thank you.
Wonderful. And then Nick, you're our special guest. We're so excited that you're here. Do you want to introduce yourself and kind of tell everybody a little bit about who you are?
Yeah, my pleasure. My name is Nick Zerwas. In October, I came on board as the lobbyist for MAMES for the association. And my background, I served for 4 terms in the Minnesota House of Representatives. And over those 7 years, I had the opportunity to work pretty closely with MAMES over the years, working on several of the bills that we moved forward in the House, doing everything from pushing back against competitive bidding and rate capping to fighting against bulk purchases with the incontinence fight. And so a lot of the issues I've been familiar with over the years because it's what I've worked on behalf of MAMES as a legislator for the last several years, and made a transition late last year or early last year into the private side of things, and which allows me to be at home with my wife Beth, and I have a 4-year-old son, Jackson, that I just dropped off at daycare. And so this new role lets me do a lot of work and focus on my family, which at this point is kind of my priority right now, but certainly excited for the session to start and advocate on behalf of MAMES down at the Capitol, virtually probably,
Right.
this session. And so it's going to be a really interesting and unique year. That's how you can tell I'm from Minnesota, because you say it's interesting and unique. And there's going to be some challenges, but I think the nice thing that I think sets us apart from some other folks and some other folks in my field is with my time in the legislature and how recent it was. All of the key decision makers, we can shoot a text to, we can do a quick call to their cell phone. I had a question about an issue for MAMES yesterday, dealing with a hearing that's coming up in the state Senate tomorrow, and I was able to call both Health and Human Service Finance chairs in the Senate yesterday, and visit with them briefly. So remote session will present some challenges for us, but we're definitely prepared for that session. And I think with kind of the unique relationship that we have, we're in kind of a unique footing going into those challenges compared to some other scenarios.
Wonderful. Thank you, Nick. And I know I can speak on behalf of our MAMES members. We're super excited to have you already. Is making noise for us. And so we certainly appreciate that. So I'm sure you're going to be speaking again, Nick, but we'll go ahead and kick it off and start this conversation off. I think one of the big things that I've been getting from a lot of our members is just some questions about COVID-19. So we'll open up the meeting to you guys. The goal is for Nat to have me do the talking, but this is your opportunity to ask questions of one another. And so perhaps what we can do, just for the sake of everybody's time and making sure that we get as much out of this as possible, is we'll open it up, open the discussion surrounding some of the questions you guys have of each other for COVID-19, and then we'll move on from that and talking about what's happening at the state level. So, you know, everybody is aware of the Minnesota Medicaid going to be taking money back all the way from 2018. And so we'll wrap up our sessions kind of talking about what our goals are for this next legislative session and how important you all are in being engaged in this process. So I'm going to open it up to the group. Does anybody have any questions? We did get a few questions submitted to the MAMES office. So I'm going to open it up first. If anybody on this call has any questions regarding COVID-19 and the impact it's had on your business.
Rose, I got a quick question I was thinking about the other day, and I don't know if anyone else has heard this or if anyone has any billing or ideas. I asked if DMEs get any extra, pay or any money for all these COVID-19 setups within people's houses. You've always heard that hospitals or facilities are getting some additional money, and I just was wondering if there's anything for DMEs. I just thought of it the other weekend as we're just up here in Brainerd. It's getting really hot and heavy, I guess, as we're doing them constantly COVID setups now. So it's probably what everyone in the cities was doing earlier this spring is now up here in the Brainerd Lakes area. So I just wondering if there was anything out there to kind of help the DMEs, I guess, with getting, billing more money or something.
Yeah, and then I'll open it up to the rest of the group. But right now, there's nothing that CMS has on the books to allow us any more money outside of, they did in the CARES Act increase our reimbursement for non-rural areas. You're already probably getting mostly rural, but there's some non-rural areas you're probably servicing, and that's just a little bump up in reimbursement. But anybody else, how are you guys handling, again, the massive setups that you're doing related to it?
Yeah, we haven't seen that yet up here in Duluth, but Chad, are you on your COVID setups? Are they mostly O2? Or are they O2 and hospital beds? What are they?
Pretty much concentrators. A lot of 5 liters, but lately a lot of 10s have been going out too. Wow. The 10-liter concentrators, but pretty much just O2.
So obviously, especially with the decline in reimbursement, although Chad, most of your area is rural, right?
Yeah.
So you're getting a little bit more, but I guess the problem with a lot of these COVID setups is they're really going to be only 1 month, maybe 2 month setups. And so you're not going to get your money back if you're just going to get Medicare reimbursement. So I guess the only other option would be to do it non-assigned. And then at least you get your fees up front, and hopefully at least get enough to pay for the setup. And I guess that's about the only thing that you could do. That's probably what we're going to do if we start seeing a lot of this, because you set up a hospital bed for what Medicare reimburses, and unless that bed is going to get rented for a while, you're not going to get your setup costs back. Anyone else have any ideas?
We've had, this is Jackie, we've had quite a bit of setups up in the St. Cloud area, and we are doing, again, hospital beds and concentrators. And unfortunately, it seems like most that we have been doing have Medicaid as a secondary. So we're not able to do it non-assigned.
Yeah, that's tough.
Al, you're going to say something. And then if everybody, when you are talking, if you weren't introduced, if you can just, again, state your name and which company from, and maybe where you're from, what area you're from would be helpful too. Go ahead, Al.
This is Al Newman. We've been talking directly with some of our hospital partners because we're actually seeing more and more people without insurance. People that have been, they probably still got assets, so they don't qualify for Medicaid, but they don't have any current insurance. And this is due to the COVID and the layoffs and, all the closings. And we've actually approached some of these hospital systems on a payment program, at least to cover the first month, because they're desperate to get the beds freed up. So if you've got any kind of a relationship at that hospital level, you may want to start talking to them about some of this payment, because we can't continue as an industry to take that population on, because you're chasing your money. You're virtually doing it for free at that point, Tom, and these guys want to free up these hospital beds. So we're in conversations with Mayo and St. Cloud Health Partners. So that's Methodist and Regions. They want to free these beds up and get these people out of there. So I would strongly suggest, if you got any relationship at that hospital level, talk about some kind of fund that can be created or run through their supply chain, that they would pay for the first month rental on oxygen, obviously. And it can't be at Medicare rates. We know that. It's got to be at least double the going Medicare rate, or, I'm not, you can't afford to take it at Medicare rates on a 30-day rental. But that's just my suggestion.
Yeah, Al, this is Craig at VGM. HHS did set up that uninsured fund. You could bill COVID-19 positive patients to that uninsured fund and be reimbursed. But if they didn't have any other insurance at all, but it was at Medicare reimbursement. So that would make it tough, especially with those short-term, that point was already made, those short-term rentals. You take out a bed and pick it up in a month, you're not going to make any money at the Medicare rate.
Correct.
It's Lori with Handy. We've done this same thing. There's many hospitals will have foundation money or charity care money that'll pay for the first month. And then that's all they'll pay for, though, because they got that person out of the bed. And then we have to go in and try to bill that customer for any time thereafter. Maybe Cindy from Handy's on. I think she can probably address that too. So yeah, you get 1 month. I'm not sure if we're going to get more than that, though.
Right.
I've got another question just for the group, wondering how people are handling this. That Medicare came out with all of the rules and pretty much followed among the commercials as well, that you didn't have to get wet signatures when you delivered items. But the exception seems to be with assignment of benefits with AOB if it's a new setup. And so of course, then you're having to get wet signatures. So your options are either to take the chance that you're gonna infect the patient, or your patient's gonna infect you by getting a wet signature at the time of delivery, or you do it through the mail, in which case your cash flow gets out of whack because you can't bill until you get the AOB back. So I just was wondering how people are handling that.
Tom, this is Jackie. We mail ours out, or we email them and have them mail it, the original in.
Yeah, that may be it. Or you have them sign and, you know, you leave
Oh,
a pen or whatever. But yeah, it just seems like such a dumb rule that defeats the whole purpose of their other rules. So I don't know, Rose, is anyone at or Craig at VGM, has anyone raised this with CMS?
Yeah, we brought it up. It's been a big discussion in our Medicare Council meetings, and both Meridian and CGS has taken this issue from the get-go to CMS because they realize, especially with so many providers having their AOB on their delivery forms. So it's been a big issue from the beginning of time. We just followed up with CMS, or excuse me, with Medicare, with the provider outreach people that we work with, to indicate if they've gotten any movement from CMS on this issue, and there hasn't been any. And it's been an issue that everybody so far in all the state networking sessions we've had has been an issue for everybody, and especially early on, where people didn't realize that makes no sense that the delivery slip, right, you could, do that, but not the AOB. So there's quite a few folks nervous, obviously, for that period of time that, they didn't get that. They didn't get it. They followed the rules according to what the delivery slip says, but yeah, there's a lot of issues. But some have said they've left, when they drop off the equipment, they leave self-addressed stamped envelopes with the AOB inside. And that seems to have worked very well for them. A few folks that have reported using that, and it seems to work well.
Good, it's a good idea.
Craig, I don't know if you've got anything to add. Again, we haven't had any success, and it's all up to CMS. Again, it's stupid, but.
Yeah, not from the CMS level. Obviously, there's individual private insurance plans that may have made that change on their own, but CMS has not done anything with that. And leaving the self-addressed envelope. So is it for CMS, are you required to have it, or just have made the attempt to get it? Because leaving that, obviously they may just not even see it, may see it but not care, not fill it out, not send it back, throw it away, whatever. What's the actual requirement for CMS there?
You have to have it before you bill, I believe. Correct, Tom?
Yes.
Yeah.
Yes.
So you're going to have to follow up with the patient.
Yeah, and that's what they're indicating they're doing. And again, I think what I'm hearing from most providers from most of these meetings is, they'll get the signatures when they can. Obviously, if it's not a COVID, but they end up on those that they know for sure they've left a self-addressed stamped envelope. They're doing the phone follow-up.
Yeah.
Having them saying, make sure you send that in because we can't bill. We can't bill without it.
So this is a question maybe for Craig. Everybody's seen the headlines about the OIG going after the fraud involved with all the COVID stuff. Is there any fallout for DME, on the OIG? And again, we're talking about, what if you bill without the AOBs and stuff? Is that fraud? Again, that was the headlines this week, Yeah.
So. Yeah, we probably won't know that with all the stuff they have waived. I don't know if if they're seeing it, if they have visibility to all of that when the claims come in, or if they're going to look at it all after the fact and say, okay, here's 40% of the claims didn't have the AOBs on file, so we're going to go back and recoup that. Time will tell. I have no idea what they're currently looking at in terms of that.
Yeah, well, I'm sure we're all afraid of that, so.
Right.
Yeah, and I think, you know, again, you know, the DME Max know, and the medical directors, because we've also talked extensively with the medical directors, all of them, and they all say they all understand the issue. So I would be, I would be and I wouldn't be surprised that they would go after it hard, but, you know, pretty much every supplier out there, and I don't think it would be viewed as fraud. Only for the fact is that, you know, again, there's that misunderstanding that that was separate, and it makes no sense whatsoever. The bigger issue is we learned from the National Supplier Clearinghouse. We have an advisory committee that meets on a quarterly basis, and we thought it was very interesting. CMS obviously waived the requirements to do accreditation, you know, et cetera, when the pandemic began. And there were 700 new applications that got submitted during that time. The NSC reported last month that they sent out to all those 700 applicants that they had 30 days to get their accreditation, you know, by their accreditation, pick their accreditation, and send the letter into the NSC. At the time of our meeting, the NSC said they had not heard from 300 of those 700 providers. So we all know on this line, they would come after you and they'd probably deactivate your number because you didn't respond timely. So we asked them, so are those 300 suppliers automatically, you know, deactivated from the NSC? And they said, no, not yet. We're waiting for instructions from CMS. And that is so maddening. And so needless to say, all the providers on in that committee meeting, the NSC heard a lot, because again, that's what we're afraid of, because we do have some of those folks that came in, swooped down, and there's going to be fraud issues. The hope is that, you know, these folks that are long-term like yourselves, have a billing history, all that kind of thing. I really don't think, I mean, I think they have some flexibility. NSC is assuring us that they have some flexibility, you know, and can determine if folks really are being fraudulent or not. So again, that's just an FYI. How about any other COVID questions? We did get one submitted that I will throw out there. How are you getting in to visit with referral partners in hospitals or long-term care facilities?
To the extent we can, oh, sorry. Go ahead.
Go ahead, Tom.
I was just saying, to the extent we can, we're doing it through Zoom meetings. And, you know, it's, COVID's kind of taken all the oxygen up in the room at these places. And so I think it's tough to get their attention.
Yeah, we're just calling ahead, and if they want to see us in person, before we had this other lockdown, there was a couple of times that we'd meet on a patio and have coffee. Most often, especially not going into hospitals, they don't want us in there. They have enough going on. You know, clinics occasionally if we call ahead, but we're just being really respectful of their rules and going, you know, asking what we can do, and then doing Zoom meetings or conference calls. So, and we have 1-800, you know, free conference calls that we've subscribed to. So we're offering our number up and getting meetings with groups, and it's working out, you know, fairly well. Keeping in touch is the important thing.
Yeah, we were hearing across the country really about providers trying to call on referral sources, and they wanted some kind of proof that that person that was coming in wasn't COVID positive, had been tested recently, whatever. So I know we signed a vendor partner that has these rapid tests available. And I know some of our members are using those because they do provide quick results. Obviously, there's an expense there. You don't want to be testing your entire staff every single day, but strategically for those that are going out and are able to get into some of those referral sources, but they want that proof, those tests give them ability to say, yeah, here I tested this morning and here's my negative result. And they'll let them in then to come in and see them. But
Yeah,
We have, oh, go ahead, Al.
no, go ahead, Jack.
Oh, I was just going to say, we have a few facilities. Our service techs get tested weekly
Yes.
at the facility to prove that they're okay. We have one driver that's had, I believe, 26 COVID tests to be able to go in and do repairs. When the weather was better, I mean, it's beautiful out here now for Minnesota, but they were doing a lot of repairs outside under their awning or in a protected area, but now they are able to go in as long as they do that weekly test.
and the facility is providing the testing in that scenario then?
Yes, they are.
They're taking on the cost of the test. It's part of their protocol.
Yes, they're doing their own tests, so.
That's great.
So when anyone complains about how uncomfortable the test is, I point out our service tech and his 26 tests that he's had.
Yikes.
Yeah.
They're slowly eroding away at his nasal cavity.
Yeah.
Or his brains.
Yeah.
Al, you were going to say something.
No, that's the same scenario we've set up, but we've actually contracted too. So we have control over employee situations also. And I'm sure everybody else probably has too. So we can send somebody in for a rapid test if we have to. And again, there's several facilities. For a while, we were sending people all the way down to New Prague because you could get your results back within 24 to 48 hours. And so I know it's been a struggle to try to keep, 30 some delivery guys, on the road and tested and especially at that facility level. But a lot of the bigger facilities, they've all got the tests now. So we moved my dad out of the local facility here about 3 weeks ago, and they've got the rapid tests before you even go in and test you. So if you got to deliver there, the facility is testing your delivery guy. It's 15 minutes on a rapid test. So, but it's been a struggle.
Awesome. Anything else? Okay, another question we received is, how are you handling CPAP setups differently than you did pre-pandemic? And then followed up, what changes will you continue once the pandemic is behind us?
Screen.
Yeah. Screen and remote setups. But we are originally we were all remote setups, and then we went to allowing setups by appointment only, assuming that they get through all the screening questions, and we're still doing some of that. So right now it's kind of a little of both.
If you are doing face-to-face setups, one of the questions that came up on another call was there was one provider that were mandating their respiratory therapists to use the face shield mask, and they hated it. So they tried to force the issue, but then they're like, okay, well, what else do other providers do? And, it went back and forth. They, indicated they prefer them to wear the face shield mask. But then here, that if it didn't work for them, then they would require them to have something else. How about any of you guys? Do you have any strict requirements for your therapists on CPAP setups?
We're doing the same as Tom. Screening. If people want virtual, we're doing that. If they want face-to-face, we ask the questions and everybody wears their mask.
Right.
Just a regular mask, so you don't make them wear any.
We have the face shields and they err on the side of caution. So if they, the person has any kind of symptoms, they're putting it on, but
Okay.
they're just being careful.
We had a COVID patient walk into our St. Cloud facility last week, COVID positive to pick up oxygen. It's like, what do people?
How did you find out he was positive?
Well, you still got the deal set up front, where you screen the people. And
Right, but he went ahead and he admitted it then.
Yeah. It's like, what do people think? It's like, geez.
Well,
yeah, I need a couple of E-tanks. Yeah. Oh, by the way, I'm positive.
So Al, when people come into your store, are you screening them before they get all the way in?
Yeah, that we were. Ben, you can probably attest to that better now than I can. So
yeah, we are. We have a cordoned off area in each of the stores. So when the patient comes in, they don't have free roam anymore. They stop. We see if they've been screened. We screen them again. And that's how we've caught a couple of them who, we haven't gone back and listened to the calls to see if it was a patient we were talking to on the phone, but we've had them screened and they come into the store and we screen them in the store and they're like, oh yeah, I was just, my brother's in the car, he's COVID positive, or I'm COVID positive. And it's like, we've got signs on the doors. I mean, I don't know at this point how anybody can just do that, but it's pretty disheartening when they do.
All right. Well, any other COVID questions? That's it for the ones that came in. Any other discussion on COVID?
Just gloves, I guess. Any movement nationally on getting Medicaid nationally to do something about glove reimbursement? As I understand, in fact, there was even something on 60 Minutes on Sunday. Gloves are the one item, the one PPE item that it just continues to be in short supply. And as we're hearing from our suppliers, every single crate that comes in is a different price.
I think we're all experiencing that. And I think that's certainly not going to change in the short future, I don't think.
No, if the price is going to keep going up, I think probably for the next few months anyway.
Yeah, it very likely will. And we have seen VGM's been involved with a few state Medicaid programs already that were really low to begin with in terms of what they reimburse for gloves, down in the $4 a box range. So I think 6-7 states now have increased their glove reimbursement for the A4927 for Medicaid purposes. California quadrupled their reimbursement. Washington, Massachusetts, again, I don't know all the states offhand, but there's definitely been some movement, and some of those states were reluctant initially, but when we provided them with articles from within the industry, but also from outside the industry, showing how big of a problem this is and how many people, they weren't aware of it really. And when you show them all of the stuff that's out there about the short demand and the increase in costs and all of that, they're like, oh yeah, this is a problem. Yeah, we'll address it. And who knows what they did to address it may not be good a couple months from now. It may not be good enough. They may need to do it again because the costs do keep going up. But we've definitely seen some movement. I don't know where Minnesota falls in the overall spectrum of reimbursement. I pulled all 50 states, so I do have that. I just don't have it in front of me. But if you think that's something that does need addressed with them, I've got a lot of ammo that we could certainly provide them with that may paint that picture pretty quickly for them and get them to do something.
On that end, yesterday when I spoke with the two Senate, HHS committee chairs, and then my meeting with the governor's office, I used the glove example from our earlier call where someone had said a 600% price increase. And quite frankly, guys, both chairs and the governor's office laughed and said, well, if that's really happening, you need to report that to the Attorney General's price gouging hotline. So if there is some invoicing or documentation that we can coordinate through Rose and get to me some of the increases in price, and then some documentation to show the difference between actual cost versus reimbursed cost. It's not, I'm not saying they just flat out didn't believe me, but they were very, very skeptical when I talked about the significant increase in prices when it comes to gloves. And so if we can put some documentation together, I think that might help us as we're pushing back against the blue ribbon, as we're pushing back against just kind of overall cuts, clawbacks, all of that. That information I think would be very powerful if we can organize that into an understandable format to demonstrate how much it's gone up and the huge gap between reimbursed cost versus the actual price paid.
Perfect. Perfect.
And Rose, I'll send you, I have a kind of an article with a bunch of links to an article that I've written, but it has links to some other outside, you know, the optometry industry saying how much they're paying more. There's links to some other additional articles, outside articles that highlight the increased cost. I'll send you that.
Okay.
Perfect.
That would be great.
And then it looks, does $9 sound right a box? Is that what the reimbursement currently sits at? That's what I had pulled a couple of weeks ago.
In Minnesota.
Yep.
Medicaid, yeah.
So, you know, that's probably in the top 10 or 15 states. There's probably 10 states that don't even have a reimbursement on their fee schedule, a published reimbursement rate. But for the roughly 40 that do, the $9 is probably in the top 30 of those 40. There's probably 10 states that are above that, but none of that's even really relevant. If the reimbursement isn't covering the cost right now, that's a problem. So even if it's a temporary increase to get through this pandemic, if they're going to have suppliers stop providing gloves or provide somebody else who does pay more, that's a problem for the state. So yeah, I'll send you what I put together on that. I'll send that to you, Rose. You can get it to whoever else needs it.
You got it. And then if anybody else wants to share their examples of, you know, especially if you have a certain manufacturer, if you have any specific examples of, you know, pre-pandemic and to this date, send those examples to me as well.
Yeah, that top glove is kind of the number one manufacturer in the world, and there's some of the articles mention them and some of the things they've done in terms of price increases and that. It's pretty well laid out, and a pretty easy story to understand for sure.
Yeah, and it's not, I don't think it's price gouging on the part of suppliers.
No.
It goes all the way back. They don't even have the chemicals, enough of the chemicals to make the gloves.
Yeah, the raw material.
The chemicals are in short supply.
Yeah.
So when you've got, you know, glove demand going up globally suddenly by a factor of 4 or 5, I mean, there's just no way that you're going to be able to increase supply to meet that demand.
If there's any gouging at all that's occurring, it's way further down in the supply chain with the manufacturers or those raw material producers. You know, the suppliers are just saying, here's what it's costing me now. You're not covering my cost. You're not. It's not like you're still buying them for $3 a box and wanting to charge 25. And your costs have increased dramatically. Right.
Now, gloves are historically been such an inexpensive item. So much of your cost is really getting the gloves to the customer. That's your big component. And when you're close to break even just on the price of the gloves, you're deep in the hole by the time you get those gloves to the customer.
Yeah. Nope. I get it. I just think some documentation would help other decision makers kind of come to the realization that, we're not pulling numbers out of thin air, and that these price increases are real. When it comes to gloves, it doesn't get more basic and necessary than that.
Yeah. Well, I love the VGM angle because they've got sort of global data on this stuff. So I think that sounds pretty powerful, Craig.
Yeah, it should. And if they see that other, neighboring states or other states in the union have already made these changes, like, okay, this is a real problem. Others are addressing it. We at least need to look at it as well. Yeah, it's a pretty easy conversation to have. Whether they do anything with it, who knows? But it's a really easy conversation to have.
Do we start with Megan at the state to get that increase?
We went to her initially, Lori, and she said you'd have to do that legislatively.
Okay. So Nick, it's in your capable hands?
Well, we'll add it to the pile, but I think the big thing. Yeah, and I think the big thing is, it's kind of for me at this point, it's kind of a level set to make sure that folks that are looking at us and making these decisions about DHS clawbacks, about potential rate cuts, about all of these things, realize and fully understand this kind of mounting COVID pressure that this industry is facing right now, to make sure that everybody that's making decisions on funding and resourcing is fully informed. So I think there's that aspect of it. But yeah, if we could point to neighboring states that have had changes in their reimbursement schedule because of this, certainly we'll move forward with that type of request.
Perfect. And I think with that, maybe it's a good segue, because we're at about 15 minutes left, a good segue into the legislative side of things. So Tom, as the legislative chair for Minnesota, you want to give a 50,000-foot overview of some of the things that we're working on right now, and then we'll loop in Nick.
Sure. Yeah, the most recent thing, we went into this year, this legislative agenda, really with sort of three main topics on our agenda. And one was trying to fight the Blue Ribbon Commission. There were two proposals in the Blue Ribbon Commission that affected DME. One was to bulk purchase certain items such as wheelchairs, walkers, enteral nutrition. That proposal was universally opposed. There wasn't a single positive comment for that. It wasn't part of the original proposals that the Blue Ribbon Commission came up with, but when they didn't get the savings targets that they wanted, they went back to DHS, and DHS kind of blew the dust off a couple of their old golden oldies of bulk purchasing and going to Medicare pricing. And so those two proposals made it through the Blue Ribbon Commission, and we're a little concerned that they're going to wind up embedded in the governor's budget. They had, despite the fact that the Blue Ribbon Commission was not supposed to have any speculative savings items, the savings targets of these two proposals were each between $1 and $10 million, which in my view sort of defines the idea that these things are, they have no idea what the actual savings will be on these. They're highly speculative. And so they never should have been the proposals to begin with. But in any event, we're going to have to probably fight them. So that's those are the two Blue Ribbon Commission proposals that we're probably going to be fighting. We have had, hopefully most people are aware of this, we've had a provider bill of rights or provider protection bill that we were hoping to get some traction with this year because it wasn't a budget year, but then COVID hit, so that's kind of been backburnered. Then the Blue Ribbon Commission hit, so that's again sort of put the provider bill of rights on the back burner, but this is a bill of rights that is trying to create some protections for the industry and actually all healthcare providers from some of the tactics that the insurance companies have been using sort of to divide and conquer and sort of impose their will on providers. So those were two of our key legislative agenda items. We are also going to work on the sales tax issue. We continue to have to fight sales tax audits. Al's business is fighting that right now. I know Handy's had a battle royale in the past with their sales tax audit. I think Jackie's business is going through another sales tax audit. So that was going to be something else we were going to work on. And then while we were sort of developing the agenda, all of a sudden DHS comes in with this clawback that is based on the Cures Act, just going back sort of ancient history, but in 2016, the Cures Act was passed. It was really a bill to create funding for various forms of cancer research, and to pay for it, they decided they were going to have Medicaid go down to Medicare rates for essentially items that were competitively bid, although it didn't really include supplies that were competitively bid. But we've been fighting that and fighting the Minnesota Medicaid to try to prevent them from going to Medicare reimbursement because these two programs do serve different populations. We were somewhat successful at that, but eventually in 2019, the law was changed and it said that for the codes that were listed in the Cures Act, Minnesota had to start reimbursing at the Medicare rates for those codes. So those are codes that are common: wheelchairs, walkers, CPAPs, and a lot of your most common items. So that was changed in July 1st, 2019. The DHS did a small clawback for the period between July 1st, 2019 and the end of 2019 because they hadn't implemented the new rates. So they paid at the higher rates and clawed back those higher rates. And it was a very small clawback, and it didn't really amount to much. This new clawback is about totals about $750,000, and this is a clawback based on what they say are overpayments between for 2018 up through July 1st, 2019, and we are saying they don't have a right to do that because, of course, the payment rates weren't changed until July 1st, 2019. So how can they claw back money that was paid at the rates that were then in effect? I think it's a really strong argument. We haven't won it yet. I don't know if we're going to have to litigate over it. We hope we don't. Nick had a fairly positive conversation with the governor's office on Monday, and there's hopefully more conversations to come. But I think all the members by now should have received a spreadsheet from the departments showing what their clawback is going to be, and we're going to fight that. So that's kind of what we have on the agenda. And I don't know, Rose, have I missed anything?
No, you have not. Great job, Tom. Great job in summarizing everything. And folks, if you, just one other thing is we did send the letter back in February when, if you recall, last October, DHS had threatened that they were going to go back to 2018. So in February, when they actually put some communications out in writing, we wrote the DHS Commissioner's Office. That was one of the issues that that we were asking for clarification back in February. And in addition, we are the only state that is reimbursing, that Medicaid is reimbursing all 3 Medicare rates, including the CARES Act rates effective March 6th. So we were very happy about that. But DHS had a lengthy delay in getting the rural rates processed. So the 2 things we asked the commissioner is, the status of the rural rates reprocessing, and what about this clawback? Well, she never responded. And the DHS never did anything again on it. So we basically said, well, okay, well, don't shake the tree and make them come back. Well, then out of the blue, everybody got that letter in mid-November indicating this is what they were going to do. And so there was even a couple of reports of members that didn't even get the letter. They had to call and get a copy sent to them. So first and foremost, has anybody not gotten that letter from DHS? Fairly certain everybody did. Okay. Nick, if maybe you want to provide an update of your meeting with the governor's office.
Yeah, so I met yesterday with Haley Colkline from the governor's office. She's she does Health and Human Service policy on behalf of Governor Walz. We met for about 25-30 minutes via Zoom, and I kind of talked through the challenges that the industry is facing just as a whole in this kind of pandemic time, and the pressure that our members are under, trying to help, especially in the metro and greater Minnesota, trying to be good partners with hospitals and help get people back into community, patients back into community, and keep hospitals available and open for the most severely ill patients, and the stress that places on to the industry as a whole, and as we're doing COVID setups and increased costs for basic supplies, and now facing kind of the threat of lowered reimbursement rates and clawbacks that go back, said that they want to go back prior to the enaction of the fee schedule. And so kind of just talk through all of that. And then Haley's fairly new in this role. And so I went back, kind of even back to the incontinence products, the bulk purchase, and the challenges that we had with the department at that time. And quite frankly, the discovery materials that came out as a part of that lawsuit and the FOIA request, and quite frankly, just how negative and combative individuals within the agency that should be partnering with us and helping us serve Minnesotans, just how negative and nasty, just in their basic communications, they were directed at this industry and in sometimes specific providers. And really said, there's just been a significant breach of trust, where quite frankly, I said, you have an issue and a concern when I have specific members of this trade organization that contact me with, and they name specific state employees and regulators as kind of the bane of their existence. I said, the trust here has just been destroyed over time. And so my big request and ask was twofold. One, that any clawbacks or any move to lower reimbursement rates or anything, or take money out of the hands of providers at this point, all of that be halted immediately until we as a state at least get through the, pardon me, until we as a state at least get through the pandemic and to the other side. It makes no sense that the industry we are relying on as a state to help clear out the hospitals and take care of people in the community, we are trying to take money out of their hands and trying to further reduce the amount of revenue they can take in, while it's well known that that industry is facing rising costs and significant challenges. And so my first request was any attempt at clawbacks or changes in lowering in reimbursement rates, wait until we are through the public health emergency and done with the pandemic. It needs to be all hands on deck, and we need to all be working together to ensure the health and safety of Minnesotans. And so she is working on that, and she's looking in to that delay. And then number two, my second request was kind of to try to do a level set. The new state Medicaid director is Matt Anderson. He comes from the Minnesota Hospital Association. He's new to this role within the last several months. He has not been present for the previous fights and kind of targeting of us from DHS, like a lot of the current staff have been a part of that process and that long-term kind of obsession with coming after DME. And so my request is, let's elevate this to the point where we take all of the old usual state players out of the mix, and let's meet directly with the state Medicaid director and try to do a level set on this so we can have a discussion and hopefully let cooler heads prevail and get some of the personalities and the people that have been coming after us with really this personal level of vitriol. Let's get them out of the equation and try to get a clean slate. And so she was receptive to both of those requests and said that she would get back in touch with me by the end of the week.
Yes.
Yeah, that's great, Nick. I talked to Bill Ambert, who's our lobbyist, obviously this year, and he was going to talk to Ms. Swanson and Hatch about creating a letter, and whether it's for CHM or for MAMES. He thinks that they can create a look at this and create a letter. So I'll sit on that, but
yeah,
they want to address the legality of doing that without the legislation's approval, and specifically the clawback. Bill thought that they could put something together.
Al, I can't hear you.
Yeah, I think we lost Al for.
Anyway, yeah, they've done some work for MAMES in the past, back during the government shutdown, and did a good job. And anytime you can hire two former attorneys general, and this letter, we're basically going to write 90% of it. And, it's pretty much done. So, get them to sign on, put their name on it. And that certainly, from a PR perspective, when you get a letter signed by Lori Swanson and Mike Hatch, when that hits the governor's office, that's going to get a little more attention than Sam Moravich. Even though Sam is technically, he's super, he knows all this stuff, but in our experience, we don't get letters out of Sam for, $500 or $1,000. So hopefully we won't need to go there based on Nick's great conversation with the governor's office, but something we got in our back pocket.
That's great. That's good news, Bill.
Yeah, it was just a thought I had talking to Al after a meeting yesterday.
Oh, so you haven't talked to Lori or Mike about it?
I put a message in yesterday afternoon. Okay. I haven't heard back, but I'm sure I will. And I've used them periodically through the years for different clients. Even when Mike was on his own before Lori moved on, because he does bring that, some PR value to the cause. So I've used him pretty successfully and pretty cheaply with some other clients over the years.
Well, good. Well, this is it's a pretty simple argument. As we used to say in the law business, a dog with a note in its mouth ought to be able to go into court and win this one. So we'll see what happens.
I've never heard that one before.
Oh, really? Yeah,
I love it.
That's an old one. Salespeople use it too.
Yeah.
A dog with a note in its mouth should be able to sell this line of business. So.
Well, you learn something new every day. I do know we're at they're 5 minutes after the hour. So with
Gail's
that,
coming back.
yeah. So with that, there is another thing. I know several of you had submitted a request for a hearing on the Minnesota statutes about there was some take back or whatever monetary. Can't say it off the top of my head, but check your email address or check your email box. They did indicate that we did not meet the requirement to request a hearing, that we must include the portion or portions of the rule in which the person objects or a statement that a person opposes in the entire rule. So we'll look at that and see what section we're opposing, and we'll get that out to everybody if you did try to request a hearing and subsequently got the response from the state on that. So does anybody else have anything they want to bring up before we close this session? Has this been a helpful session for everybody? Is this something you want to see in the future?
Yeah, I think it's been good.
I agree.
Very good.
Oh, this has been great.
I think we should do one once a month.
Feedback?
Yeah. Yeah, great job, Rose.
Yeah, thanks, Rose.
You betcha. Well, thanks everybody again for your time. This was super fulfilling for my end, because just to be able to hear from everybody and for you guys, especially to meet Nick, our new lobbyist. And so again, if anybody needs anything or has any questions, or if you have any follow-up, please feel free to send a note to the MAMES office and we'll get it taken care of. But with that, thank you everybody. We hope you have a great rest of the week.
Thank you. Thanks,
Thank you. Everyone have a great holiday season.
You too.
Alrighty,
You too.
thank you.
Thank you.